Nowadays, a lot of demand for your subspecialty. In Mexico, we witnessed it. The entire hall was packed.
Yes, sir. Yes, sir. Till actually we started going there, we also didn't know, sir, what to do, how to do and all.
Okay. A lot of demand for andrology infertility. It's good. People are showing interest in not just stone and prostate. They want to learn other things.
Yes,
That's
sir.
good. Yes. Yeah. So we'll just start in another 2 minutes. I'm waiting for people to join. In the 2 minutes, Dr. Karthikeyan is ready with his presentation. So this is the first talk in our andrology series. We finished our infertility talks, 4 talks. They're well received by the students and the other consultants. We hope that we continue this academic activity every fortnightly. And I thank all the participants for joining in previous programs and forthcoming programs. The next talk, next
Praveen Joshi, sir.
Praveen Joshi. So
Medical management.
Medical management. Okay. He's from where? Praveen is from where?
Bangalore, sir. Bangalore.
Okay. I think we'll start.
Okay, sir.
Good evening, everybody. Welcome once again back to our ASU Smart Class academic activity. In the last sessions, we dealt with the infertility talks. We had a very good discussion. The speakers were excellent in communicating with their knowledge to us. And all these talks were recorded. We are very soon going to put in our ASU YouTube channel. Now, from today, we are going to start the andrology session. And the convener for this session is Dr. V.S. Karthikeyan, and he's going to talk on the evaluation of erectile dysfunction. So before I ask Dr. Karthikeyan to talk, I would like to introduce Karthikeyan to our audience. I'm very happy and surprised to see his CV. It's got a very, very impressive CV. He's a microsurgical andrologist and urologist, Apollo Hospitals, Chennai, Apollo Fertility, Annanagar, and Karapakkam, Chennai. He did clinical fellowship in Delhi under Dr. Vineet mentorship. He also did the clinical observership at Miller School of Medicine, Miami, under Dr. Ranjit Ramasamy. He also did male infertility diploma from Brazil, North Carolina, and Hamburg, Germany. He's a member of Global Andrology Forum, American Center for Reproductive Medicine, Cleveland. He is also a member of IMA Standing Committee for Men's Health, member of USI Collaborative Research Panel, council member of USI Andrology Section. He is the editor of Men's Health Society of India, member editorial committee, Indian Journal of Urology, member USI ED Guidelines Panel, and founder convener of USI Andrology Section. Very impressive. He is also is a receiver of Young Urologist Fellowship 2019 from UAA, Urological Association of Asia. He also is an awardee of MIUC Traveling Fellowship 2018. Also an awardee of UREP 2015 Traveling Fellowship. He is also a winner of Sitaraman Memorial Essay Competition of the USI. He is winner of Davangere PG Symposium winner. And he's a gold medalist and the best outgoing student from Rajiv Gandhi University of Health Sciences, Bangalore. And he also is the best outgoing student of MBBS from JIPMER, Pondicherry. So, Karthikeyan, I think your CV should be inspiration for many youngsters, and very impressive. And now I request you to take over and to give your talk on andrology, evaluation of an erectile dysfunction. I'll make host. Yeah. Now we can share your screen.
Okay. Good evening, sir. Good evening, everyone. Thank you, sir, for the generous introduction. So actually, as I was telling, when we did MCH, we were inspired by your teaching and we learned many things from you in the mock exams and all those things, sir. So carrying that forward, this andrology meetings nowadays, like we are facing more and more patients. So it is important to have a knowledge about male infertility and male sexual dysfunction. Thank you, teachers, consultants, senior consultants, and residents for joining in this session. And thank you, Suri Prakash sir and Association of Southern Urologists for giving me this opportunity to present on the first of the series of erectile dysfunction lectures. This will be on evaluation of ED. So before going into the exact evaluation, we should understand why this is important to evaluate ED. So why not just give some medications and see, just do the routine blood tests and go on. So what happens is almost 50 to 60% of the times, the treatment of ED is very important and it actually affects the quality of life. There are many couples we are now seeing where ED is causing infertility as well. And there is also a strong association between ED and infertility in many people. So we have to see what is causing this ED. So we have to identify the cause and pathophysiology. Like in any disease, that is the base on which we do the treatment. Second thing is how severe is the ED. For example, when we see an unconsummated marriage, maybe after 5 years or 6 years of married life, that means that the condition is very severe and maybe it is very important and it is an emergency situation for that couple. Really, when they come to us after seeing everybody, when they reach the specialist, they have to we have to understand their situation. So that is very important. And again, prognostication of ED. So whenever we give a medicine, the patient may expect immediate improvement and they may come back and tell you gave medicines, there was no improvement. But then we have to prognosticate the ED in the OPD itself so that we can tell them that you try these medicines, we will give them hope. But then we can also tell them that this will be the extent to which we can expect improvement and come back at this point of time and then plan the further course of action. So the algorithm for ED evaluation should be private, confidential, and non-judgmental. And it should, as usual, it includes the onset, duration, what are the comorbidities, severity, and the etiological diagnosis is made. Here we do the medical and psychosexual history by using either standard protocols or by using standard questionnaires like the IAEF. However, we have seen that the IAEF is not very easy to comprehend. So many a time we have to sit with the patient and help them to fill the questionnaire. So we also during the history identify other problems other than erectile dysfunction, sometimes ejaculatory issues, sometimes issues like penile curvature or say phimosis, all those things also come out. And we also in the history identify the causes, reversible factors. We do a focused physical examination to see penile deformities. Is there a prostatic disease, hypogonadism, and what is the cardiovascular status? Then we go on to tailor our lab tests based on these things. So based on the risk factors, the physical examination, and the other things which are mentioned here, based on this, we tailor our lab tests. And then the routine things which are recommended are glucose lipid profile and total testosterone. We will come to that later. So just before going into that, we will have these 3 case scenarios as our baseline. So what are the common scenarios we see? It may be an adult around 45 years, middle-aged man who comes with subacute onset of ED, say for 6 months to 1 year, and there is no significant improvement with PDE5 inhibitors. That is one group. Second is a very young patient who is newly married and again has mild ED with minimal improvement with PDE5 inhibitors. And a old male classic chronic ED long-standing diabetes with no response. So these are the categories which we commonly see, and there is one more very important category where it's a young male married for quite some time, maybe 5 to 6 years, but the ED is so severe that penetration is not happening, and that itself is causing infertility and commotion in the family. So these are the basic things where we give our best so that the patient responds to treatment. So as in any history, so the presenting symptoms will be about erectile problems, and hand in hand, whenever we're dealing with male sexual problems, the ejaculatory issues also come into the picture. Most common is premature ejaculation. The other things like delayed ejaculation and ejaculation, we won't discuss in this presentation. Our main focus will be on ED. So it will be duration, severity, and associated symptoms, and onset, whether it is sudden or gradual. Again, these things are very important to. There are some situations where we always think that a sudden thing is psychogenic, but then there are some situations where even a hormonal issue like prolactinoma can be a sudden onset symptom. Sudden onset means it's just in 1 or 1.5 months. The premature ejaculation, again, there should be a clear distinction. When we take history, many times we see that the patient says, I have premature ejaculation, but in the end, he has ED, and vice versa is also true. And what about the libido? So libido is very important. Whenever the patient comes with ED and loss of libido, we tend to find out whether the libido loss was earlier or the ED was earlier, because that again gives us an idea like what is causing which one. If there is, for example, ED for 4 to 5 years, then if the libido is lost, once the ED has started after 2 to 3 years, the libido has been lost. That means probably erections are not good. There are failure of intercourse attempts. Therefore, libido is reduced. That is okay. That is expected. But whenever the libido was reduced or low from the start, it means we may be also probably dealing with the hormonal issue. So details, what are the exact details we would like to collect from the patient is morning erections. Whether the morning hood is early when compared to before, how is it? So patients may be telling that I have ED, but when we ask about morning erections, they are still maintained. So that's a good thing. And the next thing is what exactly we need to treat. So not when patient comes and says ED and we write medicine, that is not the way. Very many times we have to ask, what is the main issue? So he gets an erection, they may tell that the erection is very good, but they are not able to maintain it till the time he penetrates and ejaculates. So that is one part. Or sometimes there is a very difficult time in getting an erection itself. So that's a different thing. And many people will come and tell I'm having ED, but when we assess, everything looks normal. Then we ask them, what do you mean by exactly ED? Then they tell that for the second or third attempt on the same day, my erection is not good. So those things are very important to note because that actually differentiates the treatment. Next is frequency of intercourse. How frequent the couple is doing intercourse. And sometimes we also see that ED can be with one partner, and with multiple partners, sometimes the erections are better with the maybe the partner, there may be two wives. All those situations also to be taken into account. Consummation is a very important thing in especially newly married or the initial 5 to 6 years of married life when infertility is there. It is our responsibility to ask about consummation because the couple would have completed all the evaluation, but this consummation part would have sometimes been missed, and that is the cause for infertility. And one more thing is regarding masturbation. So whether he does masturbation, whether the erections during masturbation are the same as during intercourse or they are better. That again gives us an idea that the patient is preoccupied and he is less confident during intercourse. Therefore, his erections may drop. But when it is masturbation, he is good. And orgasm and ejaculatory function also are important part of the history. Again, here, this masturbation, this orgasm are also very important when we are dealing with ejaculatory issues like a delayed ejaculation or an ejaculation. Again, that is outside the scope of today's discussion. But these things can have a bearing on the treatment of ejaculatory issues also. Again, what the patient feels. So if he feels that his penis is becoming short or the penis is already very short, that again shows that the patient is too conscious about his genitalia and erections. Is there a curvature? Is there a painful erection? Associated symptoms like especially when we are dealing with PE, testis pain, painful ejaculation, urinary symptoms, and phimosis come into the picture. Again, sometimes we see men who come that I want to get married now. So they come and tell only that, and I want to assess my erection. The erections are very good. But then we go into the deep into the history, we identify that their sexual orientation is different. And sometimes again, what is the partner's preference, expectations, and desire? What is their idea about libido and orgasm? These are the finer points which we can take in our history. We also can assess whether there is symptoms of hypogonadism like reduced interest, erections, whether the erections are less strong. That is itself, by itself, it is a sign for testosterone deficiency. That is why testosterone features in all our erection ED assessment. So they say that if you 7 questions out of these 10 are okay, 7 out of 10 is positive, then it means that it is a testosterone deficiency is possible. But then it is this questionnaire itself is very non-specific at times. So even a routine vitamin deficiency, vitamin D deficiency, some depression, all these things can cause these things. So it is just a guide. When we have our own assessment from history till examination and comorbidities, we have an assessment that testosterone deficiency may be there. So comorbidities again for classification of ED into arteriogenic or psychogenic, and whether diabetes is under control, whether the patient has difficulty in climbing 2 flights of stairs, because ED is a marker for heart disease, and a sexual intercourse is equivalent to climbing 2 flights of stairs in 10 seconds, and that is equal to 4 minutes. So that is why this part comes into the picture. What is the significance of difficulty in climbing 2 flights of stairs? That may denote heart disease. And all these things are markers of heart disease. And sometimes psychiatric disease, psychiatric medications can themselves cause erectile dysfunction and ejaculatory issues. And again, prescription drugs, nitrates, the very important history when there is a cardiac disease is whether the patient is on nitrates, because as I told, from here itself our treatment starts. So if they are on nitrates, that itself is indication that we cannot write PDFA inhibitors. Even today we had a patient who came at around 60 years. They have ED for 10 years. Now they have come to us for treatment. He has kidney disease, he has heart disease, due for angioplasty, but they want treatment for ED. So there the treatment is very simple. It may be an intracavernous injection or a implant. But then when he is on nitrates, we have to be very, very careful. We should not give PDFA inhibitors. So that is the point which is most important on history, to identify what is the severity, what is the expectation, and what are the other drugs because of which we can tailor our management based to that. Personal history, again, smoking, tobacco, substance abuse, these are all risk factors, etiological factors. And if the diet, exercise, and lifestyle is not okay, then that also can be inculcated along with the treatment so that we have an overall response. Subjective assessment here, as I told, we all know the IIEF, but maybe it is at times difficult to employ this. So in the OPD, we routinely follow the erection hardness score. This is how it is. So it is 4 graded cylinders of rubber, where this is the soft grade 1, where it just enlarges, but it is not hard. It is hard, but not enough to penetrate. This is hard enough to penetrate, but it is not fully hard like the EHS4. This is in fact very easy for us. We can even assess our improvement in office erection tests with this tool, and we can also assess the treatment effect with this tool. Patients are very comfortable with this. This is what we are now routinely using in the OPD, and this is mainly used in research purposes. That is what we are doing. Examination wise, so as we are dealing with a vascular issue, so height, weight, BMI, all the things related to obesity and cardiac health, everything will come into the picture. As we are dealing with hormonal issues, secondary sexual characters, gynecomastia. And for our treatment part, what is the penile length? Is there a plaque, deformity, curvature, phimosis? And especially if there is infertility, all these things come into the picture. What is the testis volume? In both the infertility and ED, it is important. And presence of vas, especially in infertility. So this is how we measure a stretched penile length in either a supine position or standing position from the tip, from the pubic bone to the coronal sulcus in full stretch. That is how we measure the stretched penile length, either with a scale or with a vernier caliper. And Peyronie's plaque palpation is also important. So this is a standard measurement which we do for all our patients. That gives us an idea as to how long the problem has been. If there is an arteriogenic ED which is long duration, sometimes the penile length may be small. And also the penile consistency. If the cavernosa itself feels very firm, that means probably there is a vascular issue, and we also look for plaque in the penis. So next thing would be a very important differentiation, whether it is a psychogenic ED or organic ED. So psychogenic ED, usually they say it is sudden onset, it is situational, maybe with one partner, and early morning erections are usually present, and it is absent in severe psychogenic ED. Organic ED, this is gradual incremental progression, global dysfunction is there, that is on every attempt it is a problem, and poor early morning erections. But we have to note that not all our EDs can be dichotomized into these two. It is either psychogenic or organic. It is not possible to tell. Of late, we are seeing wherever there is an organic ED, there is some psychogenic component. And whenever there is psychogenic ED, we think that 26 years he may be having a psychogenic ED, but we are surprised to see that it is organic, because on our erection assessment, the erections are not good. So in organic ED, we have vasculogenic, which can be arteriogenic or venogenic, cavernogenic, endocrinologic, and neurogenic. So again, the importance of history, because in neurogenic, the dictum is injections work better than tablets. So whatever from starting from post radical prostatectomy ED, post pelvic surgery, any ED which comes, or post say retroperitoneal lymph node dissection, even post urethroplasty, we see that this EDs improve with intracavernous injections when tablets don't work. Cavernogenic, usually the Peyronie's disease and say post-penile fracture, post-priapism, etc. come here. In vasculogenic, we usually have the diabetes-induced or atherosclerosis-induced arteriogenic ED and venogenic ED, again due to diabetes, and endocrinologic because of diabetes or low hormones like testosterone deficiency, etc., or a prolactin problem. So these are the most common things which fall under these categories that guides us into the treatment. So at the end of this stage, we can understand that we should take a comprehensive medical and sexual history in every patient. We can use validated questionnaires, include a physical examination, and also to identify the underlying condition and other genital disorders. Lab test, at least the glucose, lipid profile, total testosterone, and specific diagnosis, we are coming to that next. So again, based on this algorithm, what we do is we do the biopsychosexual model. That is what we follow in the evaluation of ED. So that is sexual function assessment, medical history, and also what is the mental state of the patient. Is he really stressed about these things? Is there a partner conflict? So all these things come into the picture, especially in less than 45 to 50 years age, and especially when in the initial 5 to 10 years of married life, if there is an unconsummation of the marriage, all these things are very important. So we do HbA1c or fasting blood sugar, fasting lipid profile, testosterone, and other things as per the case. So these things we all know, so I am skipping it. Coming to the next thing. So next thing is, apart from whatever we have been discussing so far, now comes the most important part where an andrologist is different from a, say, a sexologist or anybody who is not practicing routine andrology. And this is possible for every urologist to do these things. So we can do the office sildenafil test and the diagnostic intracavernous injection. After adopting these things, we have seen dramatic difference in our treatment outcomes. Because one thing, the patient may come with a lot of stress and anxiety. Once even a premarital ED who comes with the erection issues just before marriage and all those things, or a post-marriage around 40-45 years, when his life is settled, again he comes back with ED. At that time, when we do the test, and if it was more of a psychogenic, less of organic, and if the office assessment gives a good direction, there itself the patient becomes very happy. He knows that my erection is good, so I don't have much problem and medicines can cure me. When he comes with that amount of stress and we give this response to him, there itself the treatment starts. And again, we have seen that it is a good tool to differentiate psychogenic versus organic ED. But again, the point here to notice, in some severe psychogenic patients, even the office sildenafil test will fail. Because as we all know, these things depend upon the mental state of the patient. So we usually use 100 mg sildenafil. Now we have moved to avanafil. Whenever it is sildenafil, it is 1 hour, and for avanafil, it is around 20 minutes. We should give a private room, and we have to ask before doing this test whether the patient can do masturbation and is he comfortable to do the test. These things are explained to him. We explain him that we will stay outside the room and we will give you sufficient time, and we will assess your erection once you are ready, and we will compare it with the EHS tool. So we can know what was the pre-OST EHS and after OST what is the erection hardness score. And based on that, we can decide the treatment. If it's a severe condition, or we know that it is almost sure that it is an arteriogenic ED, we immediately progress to the next step, that is the intracavernous injection. But if it is okay case, that is, we see that around 50 to 60% chance is there for PDE inhibitors to work, and the erection has improved. Say he came with erection 2 and now it is 3. We start them on medical treatment plus the lab investigations, diet, lifestyle changes, and then we proceed. The one more use of OST, what we have seen is premarital men who come with tight foreskin. But when we examine him, they will be normal. So we do the office cell field test and see if there is a tight foreskin, then we can suggest circumcision. That we have seen at least around 10 to 15 patients we have seen in the last 1 year, where we can take a decision based on this. Because when patient says there is a tight foreskin, we may not be able to see. We see that it's perfectly clear on examination. But only when the erection comes, that is a problem. And he wants it to get it corrected before surgery, before marriage. So that time also, this helps us to take a decision. And again, congenital curvature also, this can be used as a test. So next is when to do testosterone. So testosterone, what we follow is whenever there is associated infertility, we obviously do testosterone. Other than that, whenever there is a reduced libido, whenever there is obesity, diabetes, or already they have taken medications, there is no improvement, and reduced interest in sex and all those things, then we add testosterone to the diagnostic thing. So as we all know, testosterone is from the testis through the LH action on the Leydig cells. So whenever we deal with say a long-standing problem, we can, in infertility, we can do all the hormones, but in ED, we just do testosterone and that is sufficient. One more thing to add here is, which is not mentioned in the EAU guidelines and all those things, is addition of estradiol. Estradiol is peripheral conversion of testosterone to estradiol happens in the peripheral fat, and especially in obese people, this estradiol is more. And whenever there is aromatase activity is more, again there the estradiol is more. We have seen that testosterone may be okay. This estradiol is more useful when the testosterone is less than 300 to 350. But in obese people, whenever we see the estradiol is high and the ratio is less than 10:1, that is the testosterone to estradiol is less than 10:1, this correcting this estradiol with aromatase inhibitors also helps us. And next thing is, whenever the testosterone is less than 150 to 200, we can do prolactin. And whenever the prolactin is more than 50, we can do an MRI. So this is the diagnostic algorithm for testosterone deficiency. Next thing is when to do a bioavailable testosterone. Routinely, we don't do bioavailable testosterone assessment, and we don't directly do free testosterone test. We do a calculated bioavailable and free testosterone level, because this is supposed to be more it is more accurate and reliable. So when we expect that there is a SHBG problem, when there is obesity, when our condition is not matching with the clinical picture and the testosterone shows low. In obesity, the testosterone shows low, but it is usually in the range. When we do the SHBG and when we do the calculation, the bioavailability comes to more than 160. So routinely it's okay. But when there is a kidney disease or obesity, and our treatment has to be tailored, especially when there is associated infertility or there is a severe libido problem. At that time, these things come into the picture. Routinely, as a first-line investigation, we don't do SHBG and albumin and bioavailable testosterone calculation. We do only total testosterone. Coming to intracavernous injection, whenever there is a failed office test, after that failed medications, or when we know that there is a vascular disease for sure, and in very preoccupied people, or where there is a very, very severe, significant doubt about erection, and for curvature assessment, we can do intracavernous injection. Routinely, papaverine is used, but here what we are doing is we use the bimix, where we use papaverine plus chlorpromazine, because it has two drugs. There are two actions, and the false negative rates are less. So we use bimix. And severe cases, we can use the trimix, where we can use the alprostyril along with this bimix. The challenge here is to acquire the chlorpromazine and alprostyril. Alprostyril is not routinely available as a caverject, which is available elsewhere. So we have to buy the alprostyril and dilute it. Similarly, chlorpromazine is available in Delhi, so we can purchase that and we can make the bimix ourselves. And whenever we have a doubt, we can use the diagnostic intravenous injection with at least a bimix, which gives better results than the papaverine. Also, when we add the chlorpromazine, the volume of injection comes down, so it becomes easy for even the patient to do a self intravenous injection later. This again bypasses the neurological and hormone influences in assessing the penile vascularity. Therefore, this is more objective. Still, we see in severe psychogenic ED patients, this intracaverous injection also may fail. So at low doses, it may fail, but usually after 20 units, 30 units, it is, if it is not becoming erect, then probably it's an arteriogenic problem. But in some cases, it is very, very difficult in the initial stages to make it out. So we see that the injection is not working, but then when we give medicines and after counseling and after stress reduction, the medicine started working. So that is not the time to immediately plan for an implant. There comes the assessment of the patient. We should take a detailed history examination, assess the mental frame of the patient, and then go on in our treatment. Prolactin, as I told, it's not a first-line test. It is used when the testosterone is less than 200. There are other things like headache, raised ICP symptoms, visual symptoms, ejaculatory problems. Young male, sudden onset, no improvement with medications, even the injection. So this we are seeing now routinely. When even we see that the man is okay around 27, 30 years, there is absolutely no history to suggest a vascular problem. HbA1c is normal, fit person. But we see even the injection is not working. That is an indication for prolactin. Even the testosterone is normal in these patients. We see patients coming with prolactin of up to 400. We have seen such men. And treating that prolactinoma or a hyperprolactinemia has actually reversed the symptoms. Known head trauma and reduced smell again can cause a damage to the hypothalamo-pituitary axis. There can be a pituitary stalk avulsion, and there again, these tests come into the picture. So during the erection assessment, when there is a plaque or a curvature, we use the goniometer to assess the curvature. Cardiac evaluation, as I told, climbing 2 flights of stairs in 10 seconds is equivalent to 4 minutes, and that is a guide towards doing echo and TMT. We use the Princeton 3 guidelines, where whenever there is an intermediate risk or a high risk, we do the cardiology evaluation and then come to our treatment. We can go up to doing a TMT and taking a cardiology consultation, not to send every patient of, say, more than 50 years with diabetes to a cardiologist for opinion. If we assess our history, if there is no shortness of breath, if he is able to, say, climb 2 flights of stairs with a good, decent level, and if there are no palpitation, no chest pain, sugars are controlled, then it's okay. We can do echo, sometimes a TMT, and at that stage, we can start taking the cardiology consultation. This reduces the load on the patient, load on the cardiologist. We can actually discuss these things with our cardiologist, and they can give us a protocol. That's what we are doing. And we will send a patient when an angiogram is necessary. So that is how we work, so that we can go up to that level and then decide about giving PDE5 inhibitors. Whenever there is severe cardiac failure, sexual activity itself is deferred. So as I gave the example of the patient today, so they have renal failure, cardiac failure requiring a cardiac stent, and the heart itself is not functioning good. At that time, treating the AD may be counterproductive. That may lead to more problems. So at that time, stabilizing the cardiac condition and the edema, all those things are more important rather than treating the sexual dysfunction at that point of time. Special diagnostic tests like nocturnal penile penile Doppler with intracameral injection, and the older tests like DICC and angiogram are all having very limited role. Again, neurological studies like BCR latency, nerve conduction study, all are very, very specific, and we don't routinely follow that in our patients unless it is very, very necessary. So we also don't do the penile Doppler with intracameral injection routinely. Sometimes when there is a doubt about Peyronie's, that is one of the indications where we do this. Otherwise, we do ICVED and we stop there. So what are the indications for special tests? Young patient with pelvic or perineal fracture injury, where there is a potential chance to revascularize. When there is a penile deformity needing surgery, or there is a medical legal case or a psychosexual cause or a complex endocrine disorder, and when the patient or the partner wants a Doppler. So at that time, we do the other further investigations. However, routinely, we are not doing it. So the penile duplex scan is done with a high frequency probe, 7.5 to 12 megahertz. And it is important to induce an erection, and the blood flow is then only assessed. So if there are many people who do it with the tablet. So they may give 50 mg or 100 mg of sildenafil, or use just 15 mg or 30 mg of piperacillin, which may lead to false negative results. So that's what when I was discussing about the bimix, I told. We have seen this many times, and we have heard this in our lectures many times, that plain piperacillin with sildenafil, there can be false negative results. So in order to prove that this is a arteriogenic ED, we should give at least bimix, at least say 15 to 20 units before we say that there is no opening up of the vessel and there is no erection. Until that is done, many a time we have seen in these patients, even office sildenafil test has worked. So again, that is very important. So we all know that PSV less than 25, EDV more than 5, classify arterial and venous disease. These things we know. So this is the normal case. When there is arterial insufficiency, there is a reduced PSV. In veno-occlusive disease, EDV is more. This can demonstrate AV fistula, which can be confirmed in an angiogram. There are specific situations where advanced investigations are useful. And again, this is very important. Whenever we're doing a Peyronie's disease, at that time, even in the literature, the latest literature says that we do a intracavernous injection plus Doppler. If there is a venous leak, it is a probable indication for implant. That's the latest guidelines which are coming up now. Here we can demonstrate the plaque, we can demonstrate the curvature. And here it is a role, there is a role for pineal Doppler. Even though many practicing andrologists don't do it, this can be considered as an advanced extension for pineal duplex scan. NPTR, again, we should know about this. Maybe it is not widely available and it is not widely necessary as well. It may be useful in medical legal cases, but other than that, in psychogenic ED and other cases, routinely, it may not give us a lot of information, even though we don't have it. It is useful only in very special circumstances, and that most important circumstance is the medical legal case. Biodesimetry, again, very, very specific indications, like when there is a pineal numbness, delayed orgasm, or before pineal reconstruction, we can do the dorsal pineal nerve SSCP if the biodesimetry is abnormal. This is again some special situations where special investigations are recommended. So this dynamic infusion cavernosometry is not routinely practiced nowadays. It can be in men where there is a lifelong ED or a suspected vasculogenic leak in a trauma case. Again, these investigations come into the picture. And pineal angiogram, as we told, in traumatic arterial disruption, where there is a chance for revascularization, this can be useful. Partner interview is again very, very important. This can give us, as in studies also it has been quoted, it can affect the diagnosis and treatment in up to 58%. Whenever the partner comes into the room, we get newer insights. So the patient may tell that my erection hardness score is 3 or 4, but when the partner comes, she will categorically say that it is only 2. And that is the reason why they are not able to consummate or they are not able to have a good intercourse and all those things. Those things come into the picture. So that is one. Second thing, whenever the partner is involved in the treatment, that takes the stress off the husband, and therefore our treatment starts working better. And when the wife also starts getting involved in the treatment, the patient's adherence to the treatment and the success of the treatment also works better. And finally, it is said that whenever there is a ED in the husband, automatically the women start losing the interest and they become also having sexual dysfunction by the time the husband reaches for treatment. So these are the reasons why a partner interview and involving this partner in the treatment is also very important. So the best practice statement from the AUA is we need to take care of the symptoms, thorough medical, sexual, psychosocial history, and physical testing and the selective lab testing, and use of validated questionnaires. Counseling that ED is a risk factor for cardiovascular disease, mainly morning total testosterone. We follow the principle that more than 45 to 50 years, we can do testosterone at any time of the day, but in less than 45 years, especially when we have a doubt about testosterone, we always prefer to do it at 7 to 11 a.m. And specialized testing in some men where it is necessary to guide the treatment. Actually, in the first 4, in this level, the office lymphocyte test can come into the picture, and intracavernous injection comes little later, but that can also be a routine tool in our evaluation and treatment, so that we understand the basic pathogenesis and we can give the prognostication according to that. So just to summarize our presentation. So in history, we can utilize the IAF and the EHS, also the libido, partner preference, frequency of intercourse, and comorbidities. On examination, we also see the stretched pineal length and whether there is a plaque or pineal abnormalities. We do the official lymphocyte test, lab tests, cardiac assessment, and intracavernous injection, and special test whenever necessary. And partner interview and shared decision making with the partner is very important to have a good result on the treatment. So at the end of the presentation, now if we revisit our cases, this is a around average 45-year-old adult, where if there is no improvement with the PDE5 inhibitors, we have to see, is there a vascular cause? Is it new onset diabetes or diabetes not under control? Stress, anxiety, all those things come here, and even the testosterone part comes here. In this case, maybe it is more psychogenic, but even if we go deep into the history, we ask about premarital erections. Was there any premarital sex? All those things will give an idea whether it may be an arteriogenic problem to start with. Nowadays, we are seeing many young men who come after marriage 2 to 3 years not able to have a good erection and turns out to be arteriogenic ED where an implant is placed. So those are the situations we are seeing now. Maybe this condition is becoming more and more common now. So that again, we have to keep into the picture that it cannot be only psychogenic, it can be arteriogenic also. And here our evaluation itself is directed towards ruling out arteriogenic ED. And again, we have seen in older men, the tablets can work. So it is not that it is directly intracavernously injection always. The tablet can work. If it is not working, then we can do the injection test from a low dose to see if erection is good. Then we can switch out to tablets and then continue the further evaluation. And here testosterone, PSA, everything comes into the picture. Thank you so much for a patient listening.
Thank you, Dr. Karthikeyan. That was an excellent, elaborate presentation on the evaluation of erectile dysfunction. Now, you have some questions, no? For the postgraduates? MCQ questions, you said?
Sir. So we will go to the questions.
Yeah, you just present the questions, then we'll take the questions in the chat box. At the end, you can give answers to the questions.
Okay. Just a minute.
Yeah, okay, no problem.
Is it visible, sir?
Yeah, you only tell the questions. Answers will come after.
Yes.
Yeah.
So the first question is, which is not a part of initial evaluation of ED? So focused history, office erection test, free testosterone, and partner interview. So which is not a part of initial evaluation of ED?
Postgraduates can answer in the chat box. Okay.
Move to the next question, sir.
Yeah.
So second thing is, which is not part of comorbidity assessment in evaluation of ED? History of stone disease, effort tolerance, checking for diabetes mellitus, and pulse examination. So in these 4 items, which is not a part of the comorbidity assessment in ED evaluation?
Okay. You can answer in the chat box if postgraduates are there, if you are listening to these questions. And Dr. Karthikeyan will tell answers at the end of the session.
Next is, which is not an erection assessment tool? So office electrical test, intracavernosal injection, pineal Doppler, testosterone assessment, which is not an erection assessment tool.
Okay.
Next thing is, which is true during office evaluation of ED? So when we are doing the evaluation, what are all the points we should note? So which is true regarding office evaluation? Office electrical test is the first line test in all men with ED. Second choice, intracavernosal injection can be performed safely in the OPD. Testosterone is to be done in 7 to 11 a.m. in men aged more than 45 years. And pineal Doppler is to be done in all men with vasculogenic ED to identify the cause. So which is true?
If they have listened to your talk keenly, it's very easy to answer.
Go to the next question. Which regarding erection assessment is false? IAF5 score of 25 means severe ED. An erection score of 3 on the scale, that is the erection hardness scale, is a good erection. Ability to penetrate on history taking, that implies a good erection. And EDV less than 5 on penile Doppler is normal. So which among these statement is false? So this should be easy.
Yes. No answers.
Okay. Which regarding intracavernous injection is wrong? So bimix includes papaverine and phenylephrine. Trimix contains 3 vasoactive drugs. Adrenaline can be safely used as a downer, and self-injection is a preferred modality of treatment in arteriogenic ED, which is wrong.
Come on, come on. There are no answers in the chat box. Okay.
Which is true regarding evaluation of ED. So arteriogenic ED is seen only in elder men. The mechanism involved in Peyronie's disease is arteriogenic. Testosterone therapy is the first-line treatment for ED with hypogonadism. Early morning erections can be absent in psychogenic ED, which is true.
No answers. What is this? Okay.
Which is not a first-line test for ED in young men. So estradiol, HbA1c, lipid panel, testosterone. Which is true regarding evaluation of ED. Penile angiography is a gold standard test which has to be performed before deciding on penile prosthesis. A 12 MHz probe is used for penile dynamic duplex scan. Baseline penile Doppler is more than enough for assessment of ED. And NPTR is used to diagnose arteriogenic ED. So which is true?
Yes, come on, answer. Okay.
So last question, which is true regarding erectile dysfunction? Penile dynamic duplex scan can show the site of leak. Prolactin can be done in men with hypogonadism. PDE5 inhibitor should not be prescribed in men post-angioplasty. And diagnostic intracavernous injection can be done in men on clopidogrel. So which is the right answer?
Good. Very nice questions. They have to then to your talk, then only they can answer all these things. Okay. Then before you tell them the answers, there are some questions in the chat box. Dr. Chandramohan from Anantapur has asked this. I also wanted to ask this question. Many a times we see patients coming to our OPD, newly married, and they boys' side, the parents tell that there's nothing wrong with my son, problem is with his wife. And the wife's side, the girl side parents come and tell that the boy is impotent. So how do you evaluate a man and report who is recently married and has a dispute with wife side regarding his potency?
Yes, sir. So again, we see this routinely the OPD nowadays.
Yes,
So the thing is, if they come for treatment, at that time, our assessment is slightly different. And if it is for a medical legal purpose, again, that approach is little different. Basic things are all same, history, evaluation, all those things are same. But to prove the potency, it is always in the court of law, what we see is a penile Doppler is more important rather than whatever we do. Because whatever test report we give is all, it can be modified. So we do a penile Doppler and we tell them that a penile Doppler should be done. And if it is normal, then the potency is proved. But whenever they come for treatment, at that time, what we do is we take a detailed history, how the couple gets along with each other. Is there something other than that, like a premarital affair, the husband is not able to forget that and come into this married life, or there was some other issue because of that there is a problem. Their understanding and idea about sex, hormones, all those things come into the picture. And here we have a low threshold for doing the intracavernosal injection test. We quickly progress through the test to see whether he has an arteriogenic ED or a psychogenic ED. So even we go to the extent of calling their parents and telling them that his erections are okay, his arterial tree is okay. So give them time and they will be okay. That's how we proceed for. And we also ask them, do you want to, is this a medical legal consultation or a treatment related consultation? And that is how we proceed.
Okay. No, the thing is, we can say that there is some organic dysfunction or not. But
yes, sir. Yes.
The penile Doppler may be normal, but still he may not be able to perform.
Yes, sir. Yes, sir.
That much only we can mention the certificate.
Yes, sir. Yes, sir.
Correct.
And for that certificate, again, penile Doppler is more important than the whatever we do in the office.
Yeah. Yes.
Yes.
And in your practice, who does the penile Doppler? You do, or you ask the radiologist to do this?
The radiologist does. We go and give the injection, sir. Again, radiologist is the person who can give the official report. That will only be valid in the court of law. So the radiologist is requested to do the test, and we will go and give the injection. What we do is we do the intracavernosal injection test in the OPD. We know at what level there is an erection, and that level we use in the radiologist suit so that we get a correct report.
Okay. So there's a question from Dr. Anand. What does psychological evaluation? I know.
Who does?
No, who does psychological evaluation? No.
So ideally, it is a trained, say, clinical psychologist or a psychiatrist who is interested and knows to do this thing. That is the ideal person to do it, but it is very difficult to get them, and it is difficult to train them. So what happens routinely is we start we have a detailed history taking. We have the pro forma. We can talk to the patient in detail, and we can identify the problems. Whenever there is a real need, we take the clinical psychologist's help. Or we can train a clinical psychologist in a center which does a lot of andrology work, so that can give the correct route for the patient. So psychosocial evaluation is actually done by a clinical psychologist or a psychiatrist. But in our practice, we do at least maybe 30 to 40% of that, and then we refer to the correct specialist so that we get the rest of the information.
Okay. And the question about ESWL, I think this may be dealt in treatment, but maybe you can answer this question. Patients are inquiring about the role of ESWL in ED.
Actually, ESWT is still on the experimental level only. We don't know for which patient there will be good response. So if there is a severe arteriogenic ED where there is absolutely no erection with say lot of bimix, say 30 units, 40 units, maybe those patients won't be the right candidates for ESWT. But what they claim about ESWT is whenever there is mild ED, at that time this may work, and it may be a psychological benefit also. So that improves the psyche of the patient, and therefore medicine start working. That is how ESWT is nowadays. That is the thought about it. But in moderate to severe ED, the response may be low because these things are happening at a microvascular level. Not that ESWT may be able to improve that angiogenesis. Those who are routinely doing ESWT claim good results, but then our understanding and whatever patients we are seeing in moderate and severe ED, probably it is not working.
Yeah, correct. So the echogenicity of the corpora has any role in predicting the success of ESWT?
No, sir. Actually, maybe it is not like the kidney where the radiologist is able to give so much detail about the cavernosa, because again in the baseline the cavernosa may look the same.
Okay.
If there is a plaque in those situations, our interpretation is different. But in a routine baseline ED scan, or if we do a Doppler and if there is arterogenic ED, at that time we not be able to make out much the difference in the corporal, say, echogenicity.
Okay. So for the sake of postgraduates, Dr. Karthikeyan, can you tell about preparation of bimix?
Yes, sir. So we take 4 ml of papaverine and 0.1 ml of chlorpromazine. So it comes as a 2 ml ampule. In that we take only 0.1 ml. So that is mixed and with the 4 ml of papaverine, and this contributes the stock solution. From this, in an insulin syringe, we usually use a 40 unit syringe. We start at 3 units or 4 units. That is 0.1 ml is recommended. So that is 4 units. We start from there, and in a patient where we expect neurogenic, we start at a lower dose, maybe 2 units, 3 units also is okay. So the standard is 4 units, and we increase it by say 3 units or 4 units every time. It is not wise to do everything on the same day. We can go up to certain level. And if we reach say erection hardness score 2 or 10 units, we can stop there. We may do it on the next day. With routine use, then we can titrate more. And it is also advisable to have a downer like a phenylephrine or adrenaline. Better is phenylephrine. It is easier and safer to use it. So that can be used as a downer, so that in the office itself, once the injection test is done, we can down and we can send them so that the priapism is reduced. The chances, we need not keep thinking about it. So once we do the test, we do the downing and we send them. This can be used in treatment also.
What is the maximum dose where you say that this is enough? It's not going to. It's not
40
going
units is recommended, sir. 40 units. And at that time, it is in severe cases or in specific cases, we can do the trimix also. We can go up to 40 mcg of alprazolam, but usually we do around say 20 mcg of alprazolam and say 30 to 40 units of bimix. That is what is recommended.
Okay. So you prepare these syringes in your clinic?
Yes, sir. Yes, sir.
So it's not available. You said it's available in Delhi.
Sir, chlorpromazine is available at Delhi. We have to buy that and we have to make the stock solution. We can store it and we can, this is heat stable, so it can need not be refrigerated. It can work for 6 months.
Okay. Other questions? So what is your advice to patients who I see sometimes in OPD, they come say that they have been masturbating a lot and now they are unable to perform, got recently married. You tell them to stop masturbation or
No, sir. What we tell them is,
yeah.
yes, we tell them that these things are not related, and many people do it. So you are not the only person in that boat. So that is how we convince them.
Yeah.
And we also tell them that whatever was done earlier is not causing any problem now. Maybe since you are not developing an erection, you are identifying reasons like I have done a mistake, that is why this is happening. So if they have stopped doing that masturbation, then we can actually, they need not restart. But if the patient is even now, he wants a good erection on masturbation, we can tell them avoid penetrative intercourse. You can do masturbations whenever you want. You can even try the SOS medication along with the routine PDF inhibitors and see on masturbation how the erection improves. Based on that, he will get confidence that his erections will improve. So that is how we go, sir.
Great. Again, there's a question from Dr. Chandramohan. How routinely ED questionnaire is used in your OPD?
So ED questionnaire, we try to use it routinely, but it has, we have it translated in the languages in which we see our patients, like the Tamil, Bengali, and Hindi. But then it is difficult. Sometimes the patients don't understand it completely. And when we keep translating it to other languages, we may not be able to give the exact detail like it is in the English. We may not be able to give it in the other languages which we don't know. So it may be difficult in those patients. We can use an interpreter to give that information, but then it depends upon how much the patient understands the questionnaire. So there is nothing like abbreviated ED questionnaire less than the IEF-5. So the SHIM score is the bare minimum, that is the least cumbersome questionnaire. So we do the ED questionnaire in specific circumstances, like say perioperative ED, like post-penile rehabilitation. There are some specific circumstances where we use it. We try to use it in our practice, but maybe 50% only we are able to use it, but we routinely use the EHS. So that is what we find more useful and more easy.
Is it translated into other Indian languages? The scoring.
Sir, it is done in certain like hospitals, sir, but validation has not yet been done. Yes, sir.
Okay. So I think now the subspecialty, your andrology subspecialty can take this task.
Validation also has to be done. Yes, sir.
Okay. Another question from Dr. Dinesh Kannan. Prone masturbation, can it lead to ED or delayed ejaculation?
Prone masturbation may not lead to ED. In fact, if there is a patient, because of these things, he has a delayed ejaculation, his erections will be good. He will be able to stay inside, the intravaginal latency will be very high. It may be 30 minutes, 40 minutes. So that is what is delayed ejaculation. So whenever a patient has delayed ejaculation, in that patient, this prone masturbation is more important. But there are many people who do prone masturbation, but if their erections are okay, they're able to ejaculate, then it doesn't matter. So we tell patients that it is only a convention that masturbation is done in this position. Other positions are also okay. The other thing here is, in prone masturbation, what is the mechanism by which he induces masturbation? Like whether he rubs against a pillow or uses the hand. If he uses a pillow or a bed, all those things are more important because the pressure required for like the ejaculation to happen is more. The threshold is high. That is why there is delayed ejaculation. So more than the ED, it is regarding the ejaculation where the position of masturbation is important. If the male is able to ejaculate intravaginally, then there is no problem. Usually this question comes with regard to ejaculation rather than ED, sir.
Okay. Thank you. I think now we come to the end of the questions. I think now we can present the answers to your MCQs.
So going on to the answers. So first question, which is not a part of the initial evaluation, as everyone also knows, it is the free testosterone. Maybe total testosterone is okay, but free testosterone is not the first line test in ED evaluation.
Correct.
Other things like focused history, office erection test, partner interview come into the picture. Which is not a part of comorbidity assessment. This is easy because stone disease, there is no great link between ED, even though obesity, uric acid, that is a very complex route. So that is the right answer. Somebody had answered pulse examination, but pulse, as I told, we are dealing with the vascular disease. So pulse is important. Diabetes and effort tolerance, we know.
Yes.
Which is not an erection assessment tool. So all these three things we can visually assess the erection, but testosterone, even though it is involved in erection, this is not directly a erection assessment tool. It is a test in erection, ED, but it is not an erection assessment tool.
Yes.
Which is true during office evaluation. So office sildenafil is the first line test in all men with ED. This is a okay statement only, but as I told, this may not be, some men may not be able to perform this test. So in that way, this line is wrong. Intracavernosal injection can be safely performed with OPD. That is the right answer. In more than 45 years, the diurnal variation is not there. So testosterone can be done at any time. And penile Doppler is to be done in all men with vasculogenic ED. This is not a right statement, even though we think that with vasculogenic ED, before putting an implant, we need a penile Doppler. That statement is not okay because many a time in andrology practice, what it is recommended is, if we do an intracavernosal injection test, we have reached the maximum dose. If the erection is not okay, or if the patient is not willing for self injections, then it itself is an indication for implant. So penile Doppler is not necessary. So these things like the office erection and the intracavernosal injection, actually this data comes from the times of Rubenschasser, and it is coming like that. So these things may not be there in the guidelines, like the foreign guidelines, but this is what we have been trained, and that is what we are now practicing. So that is why these things may not be there in the textbooks also. But this is what gives a practical hands-on to the andrology practice. Which regarding erection assessment is false. So this is simple. IAF score 25 means normal. So other things we know that it is a normal thing. Yeah. Which regarding intracavernosal injection is wrong. So here the answer should be chlorpromazine, not phenylephrine. So that is just a distractor. Trimix. This adrenaline can be used as a donor. That is also okay in the office. But when we give it to the patient, phenylephrine is more safe. And self-injection is a preferred modality of treatment in arteriogenic ED. That is also right. Which is true regarding evaluation of ED. So again, early morning erections can be absent in psychogenic ED. This is a statement to be remembered. So if early morning erections are absent, it doesn't always mean it is arteriogenic. It can be psychogenic also. This point is the mechanism involved in Peyronie's is not arteriogenic all the time. It can be arteriogenic, it can be venogenic, it can be cavernogenic. Arteriogenic ED in elder men, we are now seeing in younger men also. So it is not only in elder men, it is the commoner cause in elder men. And testosterone therapy is the first line treatment of ED with hypogonadism. This is absolutely wrong. Even this is again a classical point which we have been trained. So whenever there is hypogonadism also, the first line treatment is still PDF inhibitors and the evaluation is still the same. If there is a prolactin problem, estradiol problem, or very low testosterone, these can also be simultaneously treated. But again, our treatment will be directed towards improving the vascular flow. So this is a misconception that in ED with low testosterone, say 250 or something, people give testosterone. That is not the first line of treatment, which is not a first line test for ED in a young obese man. So I just put it young obese because even then estradiol is not a first line test. Only these three things are the first line test. But estradiol is an important test in this patient because that can be the reason for ED. Which is true regarding evaluation of ED. Again, NPTR cannot diagnose arteriogenic ED. High frequency probe is used for pineal Doppler. Baseline pineal Doppler is more than enough for assessment of ED. That is not right because that doesn't give any information other than the structural abnormality. So for flow, there should be a intracavernosal injection to be done, especially bimix is preferred. And pineal angiography is a gold standard before prosthesis is not okay. So that we know why the answer is wrong. Last thing, which is true regarding ED, diagnostic inductions can be done safely in men with clopidogrel only when the patient is on anticoagulants, especially warfarin and all those things. In that situation, we can avoid ICI, but on clopidogrel, we are routinely performing the test and it is okay. Diagnostic is okay. Therapeutic may be a little difficult. PDF inhibitor should not be prescribed in men with post-angioplasty is wrong. We actually do it. So we can give the PDF inhibitor post-angioplasty if he is stable, cardiac function is good, not on nitrates. We can discuss with the cardiologist. We can remove the nitrates from the prescription of the patient and then we can give the PDF inhibitors. So if there is a SOS nitrate in the cardiology prescription, at that time we should not prescribe the PDFA because we don't know when the patient will take the nitrate. So that can cause problem. And of late, avanafil is more like they prefer avanafil because of the half-life and they can give it along with around 18 to 20 hours after the taking of nitrate. So avanafil is coming into that particular situation. Prolactin is okay and pineal duplex doesn't show the site of leak.
Nice. Even the last question I didn't know about clopidogrel. So it can be given safely, diagnostic.
Diagnostic is okay, sir. Therapeutic also is okay, but we have to give more care and we have to teach the patient about giving compression and all those things.
Where exactly you give at the root of the shaft?
In the shaft, sir, in the 10 o'clock or the 2 o'clock, throughout the length of the penis, it can be given, sir.
Okay. And you apply a compression when the patient is on
1 minute compression, we tell them, sir, so that avoids all the other problems. And nowadays, we are also using some local anesthetic spray before giving the injection, so that again, that is improving the pain tolerance.
Okay.
And it is done with the 31 gauge needle. The 40 units or the 100 units insulin syringe has a 31 gauge needle. So it is relatively very, very painless.
Standard insulin syringe, no? Or different?
Yes, sir. So actually, what we say is the insulin needle is only 26 gauge. But the one which comes with the 40 units or 100 unit syringe is 31 gauge needle. So that is supposed to be the thinnest needle available.
Okay. Thank you. So there is one more question from Dr. Chandramohan. Which component of lipid profile is more related to ED?
So LDL is most important, and which is not related is actually the triglyceride. Triglyceride can be high for any reason, but we see LDL and second is HDL, which is like more related to ED.
Okay. I have one last question, Dr. Karthikeyan. What percentage of your patients in your OPD with coming to ED will have underlying cardiac problem?
Sir, since our thing is a referral-based center, many patients will have. But routinely, what we see is at least 20% will have some cardiac problem, 20 to 30%. And that is actually increasing only. If we see more older people, the incidence will be more than the younger people. It's like that, sir. What our practice is based on that.
So elderly patients coming with ED, though they may not have any cardiac symptoms, you advise them to go for cardiac evaluation?
Yes, sir. If there is a diabetes, if the office assessment is poor, so if we are giving injection also, there is no improvement. At that time, it becomes a sign. Already the ED is worse, so he may have a cardiac problem. So that is how we go. Ideally, in a patient who is not responding to injection, cardiac evaluation is a must.
Correct. Very nice. Thank you very much. So see, you can see in the chat box, lot of appreciations for your talk. Very well presented.
Thank you very much.
So you can't, even if you read book, you can't understand. You have told many practical points.
Yes, sir. So these things, after going for my fellowship and after discussing, that is how this knowledge has come, sir, because these things are ideally not available in the textbooks.
Thank you very much for sharing with all of us.
Thank you so much for the opportunity, sir.
Thank you. This will be recorded and it will be available in our. I'm going to put all these things in our ASU YouTube channel.
Yes.
Thank you very much. I thank all the participants for joining for today's session. And myself and Dr. Karthikeyan will be there for the forthcoming sessions. I will send you all the notifications. Thank you all. Thank you very much for joining. Thanks, Karthikeyan. Thank you.